Orbital tumors. Orbital tumors represent an important cause of proptosis. Orbit contains a wide variety of soft tissue structures. All of them can give rise to benign or malignant tumors. Lacrimal gland is the only epithelial structure. Intraocular tumors can extend extraocularly. Classification of orbital tumors: vascular, cavernous hemangioma, lymphangioma, capillary hemangioma; neurogenic, meningiomas, optic nerve glioma, and neurofibroma; cystic, dermoid epidermoid cysts, sinus mucocele pyocele, lipodermoid; inflammatory, idiopathic inflammatory pseudotumors; lymphoreticular, non-Hodgkin's lymphoma, lymphoid hyperplasia, plasmacytoma, granulocytic sarcoma; metastatic, in adults, breast carcinoma, carcinoma of the lung; in children, neuroblastoma; osseous and cartilaginous, fibrous dysplasia, and orbital osteoma. Bilateral orbital disorders: inflammatory congestive processes, Graves' disease, inflammatory pseudotumor. Majority of bilateral orbital disorders not associated with a mass are benign. Bilateral orbital mass lesions often signify a neoplastic process or serious systemic disease that is likely to be malignant. Pediatric orbital tumors: congenital developmental cysts, choristomas; dermoid epidermoid cysts 37.4%, teratomas 1.1%. Vascular tumors: capillary hemangiomas 11.7%, lymphangiomas 2.8%. Smooth muscle tumors, rhabdomyosarcomas 8.7%. Neural tumors: juvenile pilocytic astrocytomas 5.6%, neurofibromas 3.7%, lacrimal gland tumors 1.1%. Bony diseases of the orbit: orbital metastasis, lymphoma and leukemias 2.5%, extraocular retinoblastoma. Vascular lesions: capillary hemangioma, a hamartoma formed of abnormal capillaries lined with endothelium. This is the most common pediatric orbital vascular tumor. Proptosis occurs in the first 2 weeks of life. Seen at birth, reaches maximal size by 6 to 12 months, and then regress by 4 to 7 years. Gross picture: sides: periocular nasal cutaneous hemangioma 90%, strawberry mark. Deep orbital lesions: diffuse orbital lesions, affect supranasal orbit and may be circumscribed. Involution is associated with decreased blood flow. Microscopic picture: irregular mass with plump endothelial cells and small capillaries. Can involve any orbital structure. With involution, fibrosis and effacement of capillary lobules occur. Involution may be induced by intralesional or perilesional steroids injection. Cavernous hemangioma, benign vascular tumor, commonest adult orbital tumor. Solitary with no systemic disease. Stationary or slowly progressive course, associated with good visual function. Gross picture: circumscribed drawn to ovoid orbital mass, intraconal with no to moderate enhancement, no feeder vessels, axial, slowly progressive proptosis. Microscopically, the following is seen: encapsulated mass, red-violet in color, stagnant blood; large vascular channels with flat endothelium and fibrous septa in between; smooth muscles in the wall of blood vessels. Cavernous lymphangioma, slowly growing choristoma formed of venous and lymphatic components. Proptosis in the first decade, ptosis and restrictive motility are present. Site: eyelids, conjunctiva, and orbit. Associated facial lymphangiomas are present. Gross picture: a mass that is diffuse and deep in orbit, congested vascular spaces extending to conjunctiva and eyelids, exacerbation, upper respiratory tract infection, sudden proptosis, chocolate cyst, hemorrhage within vascular channels. Irregular multicystic mass with blood content is present. Hemangiopericytoma, benign tumor originating from vascular pericytes. Orbital hemangiopericytoma affects adult males. There is superior encapsulated, well-circumscribed mass with enhancement. Microscopic picture: Vascular pericytes proliferation around large sinusoidal vessels which are more numerous in periphery, staghorn configuration. Prognosis of hemangiopericytoma could be benign or malignant, metastasis 12 to 45%. Microscopic picture. Vascular pericytes proliferation around large sinusoidal vessels which are more numerous in periphery, staghorn configuration. Prognosis of hemangiopericytoma could be benign or malignant, metastasis 12 to 45%. Arteriovenous communications, racemose or cirrhoid angioma. Rare developmental anomaly between arterial and venous systems. Large plexiform and serpentine vascular channels are seen. Associated AV communication of brain and retina may be present. Microscopic picture. Hypertrophied mature artery and vein with no capillary bed. Orbital varix. Saccular dilatation of orbital veins. It occurs anterior to septum. Deep orbital varix induces proptosis. Microscopic picture. Dilated vascular channels, clotted blood and thrombosis, phlebolith formation. Vascular tumors. Kaposis sarcoma. Multicentric vascular neoplasm affecting skin, mucous membrane, internal organs, and lymph nodes. It is caused by herpes virus type 8 in immunocompromised patients, HIV positive. Also could be caused by immunosuppression as in Hodgkin's lymphoma and leukemia. Origin: endothelial proliferation of lymphatic channels. Blue-red subcutaneous mass that could be solitary or multiple is present. HIV: 20% incidence in HIV patients. Microscopic picture. Malignant proliferation of spindle cells. Slit-like vascular channels. Inflammatory cell infiltrate. Intracellular and extracellular eosinophilic granules. Fragmented RBCs or giant lysosomes. Nerve tumors. Optic nerve. From the parenchyma, juvenile pilocytic astrocytoma. From meningeal coverings, meningioma. Peripheral nerves. Parenchyma, neurofibroma. Plexiform neurofibroma in context of neurofibromatosis type 1 or isolated neurofibroma. From meningeal coverings, schwannoma. Juvenile pilocytic astrocytoma, onglioma. Benign tumors originating from parenchymal astrocytes of the optic nerve and associated with early visual loss. It occurs in the first decade of life, 50% associated with neurofibromatosis 1 site. Orbit, 48%, orbit and chiasma, 24%, intracranial only, 28%. There is painless progressive axial proptosis, fusiform en masse, dumbbell-shaped if optic canal is involved. Characteristic kink in optic nerve is present. It is well-circumscribed benign tumor that appears as firm fusiform swelling with dural coverings. On cut section, there is gelatinous appearance, white nerve, arachnoid matter, and stretched dura. Astrocytes in entr'acte or chiasm. Spindle-shaped astrocytes, Rosenthal fibers, intracytoplasmic eosinophilic structures, form intersecting bundles. Behavior of juvenile pilocytic astrocytoma. Benign, recurrence, but no malignancy. Association, neurofibromatosis types 1 and 2. Nerve tumors. Neurofibromatosis type 1. Von Recklinghausen disease. This is an autosomal dominant mutation of neurofibromatosis type 1 gene on chromosome 17, characterized by formation of multiple tumors of glial cells of CNS and Schwann cells of peripheral and cranial nerves. Gross picture. Plexiform neurofibroma, diffuse proliferating Schwann cells within nerve sheaths, commonly in lateral part of upper eyelid, leading to S-shaped deformity. Numerous cafe au lait patches, increased epidermal melanin due to giant melanosomes in melanocytes. Pathology. Ocular manifestations. Iris lich nodules, thickening of corneal and conjunctival nerves, congenital glaucoma, optic nerve glioma. Others. Fibroma molluscum, pedunculated skin nodules formed of connective tissue. Absent greater wing of sphenoid, resulting in pulsating proptosis. In neurofibromatosis type 1, there is high risk of associated tumors, pheochromocytoma, carcinoid tumor, and malignant peripheral nerve sheath tumors. Neurofibromatosis type 2. This is an autosomal dominant disorder with mutation in a tumor suppressor gene producing the protein myelin or schwannomen. The affected chromosome is number 22. Gross picture: bilateral acoustic schwannomas, meningiomas, spinal cord ependymomas. Ocular features include neurotrophic keratopathy, posterior subcapsular cataract, retinal astrocytomas, epiretinal membranes, and optic nerve meningioma.